Good morning, everybody. For this session, this is our, I think, third session related to the devices. And as we know that syncope is one of the important area in which the electrophysiology has to do a lot of work, starting from diagnostic to the EP study, and later on, sometime we have to go for the devices. There are selected indications we call as a SA nodal disease, AV nodal disease, but there are syncope in which neither the SA nor the AV is on disease, and we have to decide the pacemakers. And these are the conditions we call as a vasovagal syncope. So malignant vasovagal syncope, or you can say neurally mediated syncopes. In these conditions, we implant sometime pacemaker. And the pacemaker is having a different indication. It is most of the time it is in the standby mode. It detects the particular type of heart activity and it activates. Different companies having a different protocols. So far we have discussed regarding the from the abort, which was the advanced hysteresis. Last time Devi Priya has presented that one. For the neurally mediated syncope, and their company algorithm we have discussed in detail. Today with us is from Biotronix, Mr. Thirumalaiah. He will be giving regarding the Biotronix algorithm related to the syncope for vasovagal syncope, and we call it as a CLS, Close Loop Stimulation. So these are very unique and something different from the what we call as the advanced hysteresis or rate drop, or from the Boston it is what do you call it? Sudden brady, sudden brady. Sudden brady response. So all are having a different algorithm. I will invite Thirumalaiah for his presentation, and he will give the algorithm related to his company, whatever the protocol which device follow for detection as well as terminating the or treating the syncope or preventing the syncope. So over to Thirumalaiah. Yeah, please.
So morning everyone, and thanks Dr. Ashutosh sir for giving me this opportunity. Closed loop stimulation is our proprietary algorithm of Biotronix, and it's been there for decades. So we will go through a few agenda, like what does that closed loop stimulation, how it works, and then the rationale behind the invention of closed loop stimulation, and then programming, and for different indication, if time permits, we will. Okay. So we will go through different modes of programming. So to start off, so we all know that there are a lot of sensors that are available. Very few, like so one is accelerometer, piezoelectric, and there are dual sensors from Boston Scientific. And so the major sensor that is being used in all the pacemakers is accelerometer, and it's an open loop sensor. So that means whatever we program, the physician or the technician programs, the rate and the gain, threshold, all these things which we give input to the device, that's been taken over by the device. And whenever the patient activity is there, and the accelerometer gets activated, and then the rate will be increased. So this is an open loop sensor, so where so it doesn't have any feedback from the physical activity, or like the mental stress kind of a things. So this is how the closed loop stimulation distribution of rate happens. So it's a physiological adaptation. So whenever the patient is in mental stress, or patient is having drug-induced bradycardia, then patient requires more heart rate. And those patients who are chronocopically incompetent, and those who have vasovagal syncopes, so those patients cannot have regular heart rates that is physiological. So whereas closed loop stimulation would be able to deliver those heart rates. So this is dependent on the autonomous nervous system. As we all know that the autonomous nervous system controls our heart rates also, and cardiac output. So the formula behind this is the change in inotropy of the myocardium is calculated by the impedance, which is which will come in the coming slides. So the rationale behind this is what I was telling. So closed loop stimulation is depending on the autonomous nervous system. So because generally when the patient requires more heart rates, for example, like if we are driving a car and suddenly something happens and we have to brake, and then suddenly our heart rate increases. So this is being governed by the autonomous nervous system, where so it tells the it gives a signal to the heart that no, either heart rate increase or the overall contractility increase, so that the cardiac output increases, and then it'll give the sufficient blood to the brain. So this is how the circle is being taken over. So whereas as I was telling, like the accelerometer sensor will have a open loop. So you can see here. So generally accelerometer sensors will come up to here and stop. So the sinus node chronotropic incompetent, and then patient is exercising, and then it gives rate and it stops here. So whereas in closed loop stimulation, you have that negative feedback again, that know how much and when it is to be given, even when the patient is at rest. So this is been the physiological feedback that is being given by the CLS system, which is internally calculated. So which we'll go through in the next few slides. So this is how the closed loop stimulation works. So it gives minute impedances, minus pulse of around 0.03 volts. In a duration of 300 milliseconds, it gives 8 pulses. So 8 coupling intervals in a unipolar mode, and then it takes the impedance. So as we all know, so during pre-ejection, because there is a overload of blood, and then the impedance would be low. And when we have ejection, when the contractility is happening, the impedance will be more, because a lot of tissue is surrounding the lead tip. So this is the basis of working principles of closed loop stimulation. So where so when your contractility is more, the impedances would be more. When contractility is less, it is relaxing, the impedance would be low. So this will be taken over by the closed loop stimulation by giving minute pulses, and then plotting a graph of impedance when the patient is at rest. So this is how it plots the graph, which is internal again. So when contraction happens, it starts like at the patient, when the patient is resting, it starts collecting impedance in 300 milliseconds. It gives 8 coupling pulses. So where that impedance will be plotted as a graph. So this is how it plots a graph depending on the contractility of the patient, and then the impedance curve will be kept as a template for reference. So these impedance measurements will happen during rest for continuous of 256 cycles in a row. So for each cardiac cycle, it will give 8 coupling intervals in 300 milliseconds, and which will happen for 256 cycles, and that will be taken as a curve and kept as a template for the future reference to increase the heart rate.
So that is at the time of implant, or it will be going on every day?
So when we switch on CLS, the moment we switch on, it starts collecting this data. It will not be immediately, so it will be collected during the rest.
Okay.
So the rest again, how do CLS determine this rest? So this is also a dual sensor. We don't call it as a dual sensor, but it takes the feedback from the accelerometer sensor,
Okay.
so, which is internal. So the accelerometer sensor gives the feedback to the CLS that patient is at rest now. So when the patient is resting, then it collects the resting template.
This is one-time template or all the
It's a
time?
continuous process.
Every day.
Every day, every beat.
Once beat is come one cycle, 1 to 56 beat, then again it start for 5 beats. Like that.
So it will be continuous. You're right, but the actual template will be collected during rest only. If patient is active, the template will not be collected. So so there will be minute changes for the curve, because it's a beat to beat thing. Whenever the patient rests next time, again it will have a reference curve. So there will be a small change depending on, because sometimes during because the patient is given drugs and there is contractility change. So it is not one time; it's a continuous process. So every time when a patient is rest, it will again collect the template, and there will be a small modification to the template which is previously given. So this will have a template curve. It is a resting reference curve which is there continuously. So the good thing with CLS is we don't require any special leads or tools that is required. It's a sophisticated algorithm which is incorporated in the device. So it is collected. The impedance also doesn't require high outputs. As I told, like it's like sub thresholds that is given with 8 couplets. So that has been referenced. So patient will not have any symptoms because the CLS is working or the algorithm is working. So this is how the reference template is graphed. So as you can appreciate the gap between this, so the reference curve and the I'll go back to this. So when the pre-ejection and ejection, it'll plot that graph. If contractility is more, like for example here the contractility is less, so the rate increase will be low because the impedance curve is the curve between this and this is low. So this is the reference curve, and when the difference between the reference curve and the contractility is the impedance is more, then it increases the heart rate. So this also can be set by us, where low, medium, high range of a CLS response. So if it is very high, then the heart rate will go up very fast. And we can see this in the graphs, so when we so there were studies which are done like CLS on and DDDR on. So you can see the race distribution. So wherein so the DDDR is on, the accelerometer really works there when the patient is exercising, and the recovery will be little fast in DDDR. Whereas in CLS, you can appreciate this, like the rate acceleration and deceleration will be median, and it will be physiological. So it will not abruptly drop the rates. I mean, even you switch on the CLS. And there are studies which, if we time permits, we'll go into that also. And then how do we program CLS? If I'm okay so far, so I'll go into the programming details. So any questions or doubts?
So it is in all the pacemaker, CRT, ICT, or it is only for particular pacemakers only?
Yes, sir. So we have the 8 series in pacemakers and the 7 series in ICDs and CRTDs.
8 series and 7 series, what is the difference?
So in pacemakers, we have 4, 6, and 8. That's the series name. Like, for example, Enitra 6DR, Enitra 8 DRT. Enticos 4. Enticos 4DR is the basic model, and then AVT or Enitra 6 DRT and 8 DRT. So whenever there is a 8, so that will have in pacemakers, we'll have CLS in that model, 8 series.
8 pacemaker. Okay.
Yes. In ICDs and CRTDs, it is the 7 series. So we have like 3, 5, 7 in ICDs. So Inlexa 3, 5, and 7. So Inlexa 7, BRT or DRT or HFT. So in pacemaker, CRTs in all the models we have, because all the CRTs are 8 series, CRTPs.
CRT both.
No, CRTPs alone. CRTPs are 8 series, CRTDs are again 7 series.
Means as such, most of the device, advanced devices are having this.
Yes.
How much is the additional cost when we are going for these models?
So cost, it depends, like
Roughly.
roughly maybe around 50,000-60,000 more than the usual. So the programming of the device, like, so it's all
Two things,
yes.
right now you told regarding the how the device, what are the conditions where you have not to activate? Anything is there from the company?
Not to activate, so there is
not a default mode. What
it is not default
you
mode.
have
So,
to activate it.
yes.
But patient is maybe having atrial fibrillation, where the rate is apparently changing. Contractility also apparently. Whether it is advisable to activate.
So that will not affect this, because it plots graphs in A sense V pace, A pace V pace, A sense V sense. So it has all the 4 combinations, and then only it will plot the graphs. And the impedance that it gives is so very minute, and it measures like 1 centimeters cube at the tip area. So it's not the large area that it is taking, so that the contractility changes.
2 millimeter.
Yeah, so it is 1 centimeters cubes. So it's just that surrounding that 1 mm tip which is there in that 1 centimeters cube. So it's going to be very minute unless the contractility is too much. Like so, I'm not sure. Like in atrial fibrillation, when that contractility.
All beats are having different contractility. You can't expect the same contractility. Each beat is having a different contractility.
Yes, sir. That's where I think most of the time, because if you have fast conduction of ventricle, then it may be little difficult because ventricular contractility is also more. But if your ventricular rates are mean and if it's reasonably okay, like it's not one-to-one tracking in atrial fibrillation, then it should be okay to collect because it collects during the rest. Yeah.
So we have to go how we are going to activate it.
So it's a mode itself. So the CLS itself is a mode. So instead of DDDR, so it will be DDD CLS. So in the when we press the parameters button, when we see the mode, instead of DDD, when you touch the DDDR, you will get these options: DDD CLS or VVI CLS. So these are the two options that you get. So when you program, automatically the sensor indicated rate which will be there.
How we are going to do it.
Which one, sir?
We're seeing mild moderate and right now last time we put there's a that we can change the parameter. We can keep mild or moderate or C depending upon the graph.
So low, medium, high. I'm not sure in this slide it is there. So okay, so it is on the other. I'll show at the end, sir, because I have in the other presentation. I have not taken too deep into it. So it is programming will be like a regular rate responsive accelerometer sensor. So you have a rate and maximum sensor rate, and then below is how do you want to react, like how fast, low, medium, fast. These are the three options that you will have. It will be shown there. So depending on the patient, if patient is little sedentary, so we generally select low because the patient activity is not that much. So patient is a normal patient who's active, so then medium. But there are patients who are like vasovagal and they want sudden increase in rates, and they are athletes, they want very fast rates, then we select high. So one should be cautious because these rate increase will not be like accelerometer. Even during stress, if patient is lying on the bed and if he is having some stress, if his patient is watching a movie and he has a stress, this heart rate will definitely increase depending on the contractility. So patient may feel palpitation. So we'll have to be cautious when we are programming. The default is medium. The closed loop stimulation, the activation is like medium is the nominal setting. So this is how we can see the rate distribution when we open the histogram. So how good was the activity of the patient. So you can see this is all atrial pacing. So most of the time this patient is been having atrial pacing. So we can see that the accelerometer really working. So if we don't have any doubts further, because I had the other programming parameters in the others presentation. So I'll go to few case examples. So this is a 74-year-old male. So history of AF with supramaximal ventricular rate cycling. So first they did AV nodal ablation, and so not to mention because this was on a trial. So it is nothing to degrade or do anything for the other companies. So accelerometer sensor was active and programmed, and the patient was sent. So post-implant, patient reported sudden SOB during high intercycling because he's a cycling athlete. So he was doing this, and rapid heart rate drops were there. So although accelerometer was switched on, because cycling will not have the accelerometer to be that active. So it cannot have that movement. So that won't increase the sensor rate as required by the patient. So then, so rate drops were due to measured breathing frequencies exceeding 50 breaths per minute after threshold on MV sensors, minute ventilation sensors, which was also on. Yeah. So the patient was repeatedly complaining that no, he was not able to do the cycling, and he has this. Yes, 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 yes. So this is the parameters programmed in the minute ventilation are also shown here. So I didn't go through it much. So minute ventilation on, respiratory factor is 8. So so these are the few parameters that's been programmed in the minute ventilation program. So then, so with a lot of consultations with the other physicians, and so they've decided, no, they switched the pacemaker or the CRTP to Biotronix Enitra 8 QP. And CLS rate was programmed high because he's being athlete, he requires more heart rates. And this is how the CLS, so the CLS was on, and CLS response, they kept it very high. No, the response for the this is very high, sir. So as we discussed, like low, medium, and high, and very high. So they have kept it very high, and the sensor rate they've kept at 160 beats per minute. So this is the resting rate again. So those patients who have like so vasovagal, and during rest also they require more heart rates. So this can be switched on another 20 beats. So it will most of the time try to pace the atrium. So whereas for the other patients who we know that no, they are not athletes, or like they don't have vasovagal, we can switch off this. This 20 can be switched off. So this again, ventricular, this is where the programming. So ventricular pacing is required or not required. So this is again like it is for the impedance measurement. So if the patient is a CHP and we want to switch on CLS, because the template collected will be like APVS and ASVS also. So we don't want the device to go into that mode. When we say pacing required, ventricular pacing is required, so the device will not go and check ASVS impedance graph. So that can be on off. That is generally yes. Yes. So generally this will be off, thinking that the nominal parameter is off, thinking that most of these patients are sick sinus whom we are putting CLS. And the maximum CLS rate is 160. It is again like sensor rate, which we program like 120s, 130s in the regular patients. Because this patient requires more heart rate, they have programmed 160 beats per minute. And this is how the rate distribution was. So we have something called exertion threshold rate. So which is again, when we program medium, very low, and high, depending on the parameter, this exertion threshold will be determined. So when we program very high, most of the time, the patient heart rate would be like at this range, 90 plus. And the remaining 20 will be depending on the patient activity. So most of the rates would be at these rates when we program very high heart rates. So when we program medium, this will be the heart rate, like approximately around 80. So 70 to 80 is the, so when we program very low, it will be base rate plus 70, 75 rates it will be. So this is programmable in the programming parameters. And for this patient, they've selected high, very high, and then 160 is the accelerometer sensor rate. So in the follow-up, a patient reported like, no, he has no symptoms of S4B, and patient is being relieved, and he is able to participate in a lot of cycling athletics. So and the patient is relieved from that SOBs. So any question here, sir?
No, good.
So should we go for a few more studies which are there on the?
So just briefly.
Yeah, briefly.
We have to sum up, and then we have to have some questions also.
Yes, sir. So because CLS is being tested in all conditions, like patient who's having paroxysmal AFs, not the permanent AFs. So they have seen there would be reduction in AF burden, those who have paroxysmal AF. So as we discussed, CLS tries to pace little more than the regular heart rates. So which is again governed by the impedance curve and the contractility of the patients. So because it tries to pace more than the base rate, so it as all the AF suppression algorithms also works on the same principle, that they try to pace at least 5 to 10 beats more than the regular base rate when we switch on.
atrial pacing will be more. Na?
Yes.
Here you are pacing ventricle.
No, it is atrial only.
As a 12 chamber.
Yeah, it's because it's so unless we put a VVI CLS, if it is DDDR CLS, all the impedance measurements will be in ventricle, but the rate increase would be in the atrium. So that's how this is a study which is shown that there will be a reduction in atrial fibrillation in patients who are having paroxysmal AF. So I'll not go through all this. This is again the heart test they have done in patients who are with CLS, and they have seen there is so those who had like Vasovagal Syncope and they have put CLS and they have done the heart test. They have seen sudden increase in the heart rate, although there was drops in the respiratory rate and BP, but the heart rate was really increased when they did the heart test when the patient was in the heart test. So you can see the rate increase. So they have collected the ECG and then BP also, but the rate was really increasing during heart test. So then I'll not go deep into all this.
I think it is enough.
So thank you, sir. So if any questions, so I'll take it.
Any questions from the house?
Sir, I have a question, sir.
Yeah, go ahead.
Why can't the mode be changed? First patient you have, first case study you have to put in. Why can't the mode change to VVI and sensor rate increase to 160? Why can't the patient be benefited with that? And why device has been changed to CLS?
He's having the, I think,
Yeah.
very.
So it was here 130. So they should have kept
This is the
maximum
patient
sensor
of,
rate is 160. It is already
type of
programmed.
Here is paroxysmal AF. This one.
No, this was permanent AF and they have cut off the AV nodal ablation.
So AV junction, so it may be in the PPI mode only.
Yeah, and the rate is already kept at maximum sensor rate is 160. It is there already, but still it didn't work. So that's why they changed.
Okay.
So any other questions regarding CLS? And then
Be open, there's nothing. This is the time to learn. First of all, we should not be company specific. Okay? You have to be open.
What is the ideal indication for CLS pacemaker?
CRT, yeah. Good question.
So CRT patients, as we know, most of these CRT patients are little immobile. They are not active patients. So it is always better to switch on CLS in these patients more than the active patients, because this CLS was initially recognized like for the vasovagal syncope, it really works. Whereas all the rate drop algorithms when the rate drops only, it will pick it up. But whereas CLS, it will never allow the rate to drop before even the rate getting dropped because of the contractility. It increases before even the patient. So they have seen in a course of like 20-30 years, they have seen when they put for the CRTP patient, because these are not mobile patients, when they switch on CLS, they have seen the rate distribution is smooth and the patients have better rate distribution, and patients felt better with the CRT being having CLS on. So it will have a better rate, especially in CRT patients. So that it will really help CRT patients when you switch on CLS.
Any more questions? Sure.
Thank you,
Now I
sir.
will ask the
Thank
question
you.
from you. If you are not asking, I will come. So thank you, Thirumalai. It was a nice presentation and it is a really wonderful insight regarding this protocol algorithm. I will just summarize what he has done, and if I am somewhere deviating, please correct me if at all. So first of all, CLS is basically on the premises, means on the principle that when the blood is less in the chambers, the more muscle is been in contact with the lead. So when the blood is totally filled in the chamber, lead contact is bit less. So impedance is changing. This is a simple mathematics application of what is called Ohm's law. Whole EPN device is filled with the Ohm's law. If you are knowing Ohm's, you are knowing everything. But you have to apply how to. So in this also, the protocol, what it was following, whenever the blood is less, when the syncope is happening, what is happening exactly, that we should know. So syncope type when, so let me open it first. So this is the reflex which will be developing. So neurally mediated syncope, the component is The first, the whenever the person is standing for a long time, what we call as the blood will start pooling in the peripheries, and there is a reflex which will be getting activated. Heart has to contract, and when it is contracting, suddenly it will be release phenomena will happen, and this reflex is called basal-Zarek reflex. So this reflex is responsible for sudden drop in heart rate as well as heart rate as well as blood pressure. So how to counter it? For that, different company has come with their own solutions. So in basal-Zarek reflex, peripheral vasodilation, and second part is hypotension. Hypotension is happening due to the vasodilation which is happening in the vessels, starting from the splenic as well as the peripheral veins or arteries, what you can say. But at the heart, there are two things happening. The right and left vagus nerves are getting activated because it is sensing that heart is contracting very fastly, or you can the contraction it has to counter it. So how to counter it? Reduce the sympathetic drive, increase the vagal tone. So whenever the reduce in sympathetic drive is happening, vasodilatation is happening. All the vessels are dependent on the sympathetic drive for the contracted state. So it is vasodilatation. When the vagal is going down, when vagal nerves are getting activated, so from the right and the left, there are two vagal nerves. When right is going, what will happen, and where it is innervating? It will innervating the SA node. So SA node, heart rate will go down. This is called sinus bradycardia. But if the left vagal nerve is getting activated, which can be happening if the severe vagal tone is there, it can lead to complete AV block also. So both the responses are possible. Sinus bradycardia, AV block. On top, patient is developing the hypotension. So these reflexes are there, and for that, both the companies means first, I think first Biotronix has devised something which was able to counter. But before going into that, when this reflex is developing, what we have to know regarding the what you call this head-up tilt test. So in head-up tilt test, there are three responses are there for which we do the head-up tilt test. So 20 minutes, he will be in the 70 degree. And after that, we'll give nitrate and see what is happening. So first 20 minutes is the very critical. And in that, the first 6 minutes is also critical. If you are able to see the response in the heart rate is going up, means within 6 minutes, the heart rate has gone more than 80. You can indirectly keep a suspicion he is going to be positive. This is the one way to detect. Means in the studies that has been found. And there are three responses. Type 1, type 2, and type 3. If you want to remember MID, M means mixed, I means inhibited, D means deep pressure. So these are three represent. So first is mixed. The blood pressure will drop, heart rate will drop, but it will not go below 40. So this is the type 1 we call as a mixed. Means in this both the things are there, both are going hand to hand, but it is not going to the severe degree. So we call as a mixed response. Second is the cardio inhibitory without asystole, that is 2A, and 2B is cardio inhibitory with asystole. So here the vagal tone has gone too high, then the vasodepressor is. Blood pressure is dropping at the same time, heart rate is also dropping. One time it has gone so severe that asystole has happened. There is no ventricular complexes. So it is told that if the 3 second, up to 3 second, if you are not getting any beats, it is taken as a asystole. Means there is no ventricular AV block. Either of the things means it may be sinus, or it may be when a sinus pause has come or AV block has happened. Either of the things you are going to label as a cardio inhibited type 2B, and 2A is heart rate is dropping within fall more than 10. But in all 1 and 2, to be remembered, the blood pressure is dropping, heart rate is also dropping. The third is somewhat different. The type 3, what we call as a vasodepressor. Here only the blood pressure will be dropping. The heart rate is not reducing, or it is mild reduced, but rebound increase is happening. So for type 2B is the clear-cut indication where the cardio inhibitory reflex is activated and the patient is over 40 years. In those type of patients, you have to give the choice for that you should go for the pacemaker if the recurrent syncope has happened after the lifestyle modification. So lifestyle modification, conservative treatment is the first part. Repeatedly happening, he is injuring or he is coming with the same syncope, or in which head-up tilt test 2B, you can still recommend that it is a 2A indication for going for the pacemaker. So that we have to do it. Before that, head up tilt training. Last time I told you have to keep it head up tilt training. You have to means the person should be given the chance to in the 70 degree, 20 within 18 minutes he started having hypotension, make it straight. Every day or every alternate day you are doing for some time, maybe 1 month. Later on you will see initially like at 15 minutes it was happening, later on 18 minutes, after that 30 minutes. So his body has started tuning his reflexes in such a way that it is not injuring. So that is called head up tilt training. And what I was saying regarding the indication, so whatever the this study what we are knowing, ISO3 trial was there, in which it was found that if the person is more than 40 years and younger, requires careful consideration and frequency recurrent it is happening, and if you are able to document 3 seconds of asystole with syncope or more than 6 seconds of asymptomatic pause on ILR, the patient is indicated for the pacemaker. I think this is the last one. Now coming to the question. So this is the first question. Which of the following best, everything we have been discussing now. So which is the following best describe the pathophysiological mechanism for vasovagal syncope in a cardioinhibitory? Increase in systemic vascular resistance and hypertension, sudden increase in sympathetic tone causing tachycardia, reflex-mediated increase in parasympathetic tone causing bradycardia and asystole, or primary sinus nodal unrelated to the autonomic trigger. ये सबके लिए है. Everybody has to answer it. A, how many people are ready? What is the answer? It is a multiple choice question. Sampath, Kotesh. Sorry. It is not. I should not go in that mood. So it is. I think answer is now clear, na? C. Increased systemic vascular and hypertension is not a cause that you should know. This is totally and totally. First of all, you should know it is a reflex. Whatever patient is falling, it is a reflex. The syncope is basically a reflex, a protective reflex to regain the brain circulation. Reticular activating system should get the appropriate amount of blood. That's why the reflex is activated. Unconscious means blood is not reaching to the reticular activating system. The person fell down, gravity effect has gone, blood has again come. So this is called reflex mechanism. And reflex will be activated by some stimuli. So what stimuli is activating here? What was the reflex? From where it is activated? Everything has got hand and... No. From where it is activated? Where the reflex is? This is an important question. 5 star मिलेगा जो बता देगा आंसर. Basalt xeric reflex, from where it is activated? It is from heart. In heart there is a mechanical receptors. So when it is contracting very fast, it will get activated. Is it clear? Have you seen that? That's why I was saying always see the slide slow. There was a clear cut mechanical receptors are there in the heart. So when heart is contracting too fast, too vigorously, in an empty chambers, both the things are there. Empty chamber is empty. That's why they are getting sensing. Oh, something wrong is happening. Immediately reduce the sympathetic tone. It is a reflex. So mechanical receptors are there, which is getting activated, which is there in the left ventricles. So they get activated. So those fibers are responsible for that. Okay. So reflex and sympathetic parasympathetic tone will go up, sympathetic tone will be lost, and the patient. Now next question. This is also a very simple question. According to ESC ACC guideline, which of the patient of vasovagal qualify for the pacemaker implantation? 25-year-old, positive tilt tab, vasodepressor response. 40-year-old, pre-syncope with no documented bradycardia. 58-year-old ILR confirmed asystole of more than 6 seconds duration during spontaneous syncope, or 60-year-old with a single episode of syncope during the atmospheric stress. Very simple question. C. How many people are with C? हाथ ऊपर करो. चलो 1 2 3 कोई छूटा नहीं है. हाँ चल तुम C. कोई तो आदमी बाहर आओ, ये सब के सब ब्लैक ही हो जाए तो व्हाइट सिप कौन होगा इसमें, बताओ। हाँ? टेल मी, तुम दोनों आदमी आंसर नहीं दिए। कविता ना, सरिता, सरिता रामदा, टेल मी।
C.
Chalo, this answer is very simple and it is the answer is C only. And as you know, last time I explained that persons above 40, jahan bhi hum log, wherever we have to implant, the person should be 40 above. We are not having data below 40 years. That's why we are not giving any choice. If the person develop recurrent vasovagal, it is a lifestyle modification. There you should not give a choice for putting a pacemaker. As per the guidelines I am talking, it is a different off-level indication. You can go for it if the person is having a strong history with recurrent syncope and injury. You can still give the choice, but it is a type 2A indication. Class also you should know. Whatever the classes we are discussing in the neurally mediated syncope, it is always and always only 2, no 1 indication, because we are not having randomized controlled trials. So small trials, studies, we are quoting, that's why it will be always 2A.
Maybe in the favor of the.
Yeah, in the mirror. Even though 2A is not a very less indication, it is a good indication. It is not a doubt. So persons who are having 3-second asystole, 6-second asymptomatic pause, still you are having. And what is the indication for the normal pacemaker in 6 sinus syndrome? 3 seconds and 5 seconds. 3-second pause in sinus, 5-second pause in atrial fibrillation. These are the older indications for the putting the pacemakers. Now, there is a third question. Pacing mode vasovagal. So, which pacing mode or feature helps to prevent recurrent syncope in the cardio-inhibitory vasovagal syncope? VVI without rate responsive, AI with hysteresis, triple D mode with the CLS, asynchronous pacing at fixed rate, and DDI with RDP and SBR.
E.
Hmm? C.
E.
E. How many are with the C? चलो C के साथ बहुत सारे लोग हैं. संपत, यू हैव नॉट अप एंड डाउन. यहाँ पे क्लास में सबको पार्टिसिपेट करना है, अदरवाइज इतना दूर आने का कोई मतलब नहीं बनता है. C और D? C. Okay, you are also going. तो C वाले लोग हाथ ऊपर कर लो. हाँ, okay. अब बताओ हमको E वाले आंसर लो. Okay. So there is a company bias, I am saying it. Huh? This so answer is as such C and E both. Okay. So C means CLS, what we have discussed right now, and E means DDI, means DD pacemaker. At that time it will be working. It will be DDD, not an RDP. You know, rate drop response and sudden brady response. Sudden brady is from Boston, and rate drop is from the Biotronix. I think सारा चीज डिस्कस हुई. एक लास्ट चीज था जो कि I wanted to discuss. Yeah. So advanced hysteresis last time we have discussed, but one thing worth remembering, what Thirumalai was also saying, there are two things. One is you have to counter what is happening. Means somebody has fired on you have to fire on it. That is rate drop response or Brady response. Boston's and Biotronix. They will be directly, the rate is dropping, they have sensed and they started pacing. This is the rate drop of the pacemakers, which are from the Biotronix and Boston. They are having this type of protocol. What is different between the CLS point of view, that is a contractility in activated reflex, or you can say a response, that is CLS. So in there, whenever the muscle started contracting, which is the initial part of your vasovagal, I told now, when heart started contracting, what it is doing? It started sensing and bradycardia, hypotension. So CLS is anyhow superior to RDP as well as the brady response, because they are reactive and this is proactive. Difference is this one. So if you are having a patient which is a clear-cut case of vasovagal and in which you have to do the pacemaker, it is always, means I am not going to be biased on this one, we are always having an advantage to choose in a particular CLS mode wherever possible in the device. than going for a red drop, because even after putting, the patient will be having syncope or at least pre-syncope. He may not go in the asystole or he may not going to injure himself, but still the pre-syncope symptom will be there. While if you are implanting for the CLS type of mode, the advantage is there, the patient may sense and the system is going to already start pacing related to the type of response. So this is the major difference when we are choosing a device in which the vasovagal is the indication for doing the pacemaker. Okay, so unbiased, it is an advantage to go for the CLS or the particular company Biotronix if at all possible in the scenario. Red drop is not a good choice. No doubt it is better than the dual chamber without any mode. Okay. So proactive versus reactive, this is the two difference. Proactive means device has detected that something is going to, it has sensed, it started working. And one is that already somebody has come and trying to harm you, then you are reacting. So reactive type of and ACE tool has been detected. No doubt RDP will work, but when the two A type of type patient, where the vasodepression, heart rate both are going on, there is an advantage of going for the CLS. Okay. So thank you so much. If any question is there, still you can ask.
So is there any recent guidelines on this Vasovagal cardiogenic syncope?
I think syncope, there is last guideline has come in 2020-21. After that is no. Huh?
Yes, 2020 there was.
During the corona time only it has kind of, most of the indication remains same, except for the some addition has happened for the conduction system pacing, but the rest of the things are almost same, not much different. Initially we were applying the rule of 3 second, 5 second for the 6 sinus syndrome. So there one changes has happened, that 3 and 5 second, what I was saying, which was a classical indication, 3 second pause you have to put the pacemaker, 5 second pause in patient of atrial fibrillation you should pay. That has been taken off. And there is a medical management in 6 sinus syndrome has come. You can give darifalin, try with that, or you can give orcaprine if the patient is not having coronary artery disease, which was not there in any of the previous guidelines. So medical management of 6 sinus syndrome, that's why I say to the patient, if the patient is having 6 sinus syndrome, nothing to worry. Tachybrady will certainly bring a lot of difficulty for the patient. Sometimes they collapse because suddenly the heart rate will go up and then suddenly drop. So this time the patient will be more symptomatic, but a patient who is coming with a heart rate around 45, 50, or even 35 also, we have seen the patient is walking and coming without any activity, because the body has already tuned with that lower heart rate. The behavior is predictable, so most of the time the patient doesn't develop the symptoms. He will be having some effort in tolerance like symptoms, but syncope is not usually more common in those type of patients. The patient who is having tachybrady means suddenly the atrial fibrillation has come and there is a terminated and there is a bradycardia of 3 seconds, 4 seconds, the patient collapses. So those type of patients are strictly should be given the pacemaker as a first indication. But if the patient is having only sinus bradycardia, still we are having choice to go for the pacemaker versus medical management. Put on darifalin, put on what you call orcaprine, which is elupent. See for some time if it's doing good, we can still wait. If it's not doing well, then the single chamber pacemaker is the ideal. This is the only indication where we have to go. And AI pacing is a better choice. If it is associated with the AV conduction disorder, then we have to go for the dual chamber pacemaker. Okay.
I have one example.
Yeah.
It's the red drop thing.
Hmm.
So although we have studies on red drop, switching on DVR and red drop, RDR and all that. I have seen practically one patient who was put on RDR and then the patient never got relief of symptoms. He's a cardiologist.
He is from I think Raipur. I know about this one. Both are sitting, and he has taken out the pacemaker and changed it. This is in the story of 2017 or 18, if I remember.
So far, he has never complained of this.
No, that's why I see. I was also having a very little information about the CLS, but when I have gone through the way it works, certainly it is a more pragmatic approach to the treating that particular problem than what we are doing earlier with the red drop, and that's why a lot of patients are still having symptoms. Though the severity of symptom may have reduced, but still they are symptomatic because it is not working on the mechanism; it is countering it. Okay. Thank you. Next time we'll again meet with some topic. Yeah.